I just want to first introduce our panelists. First, we have right here Dr. Alan Radin. Dr. Radin's been practicing for over 50 years in this area, and he's an internist with a specialty in geriatric medicine and is the medical director of Nuvance Health's Healthy Aging Geriatric Assessment Program, which is in Wilton and provides clinical assessments, care recommendations, and coordinates with other providers. Please welcome Dr. Radin. Next, we have Don Moyle. Don has 40 years of experience in health insurance, and 15 years ago, he founded a company here in New Canaan, Insurance Navigation. He and his team have an extensive experience with all kinds of different individual and family health insurance plans, which includes Medicare and the Affordable Care Act and corporate plans. And so he's lend some perspective beyond just the medical aspect of things. He'll help lend. Also, we are privileged to have with us Hope Hetherington, who she and her husband John moved to New Canaan in 1983. She focused on raising their two children while John worked on his both legal and political career, and she's been an active volunteer here in the community with a focus on lupus as well as breast cancer and prostate cancer. In 2020, her husband John was diagnosed with Alzheimer's, and so Hope sort of embarked on a new journey as her husband's caregiver. John passed last year, but she's sort of been looking for ways to support other people that are going through this difficult journey, so gives us an idea of what it's like to be a family member and trying to navigate your family and also your family member who's a patient through all this. So the next is Jessica Washburn-Gonzalez, who's been a practicing attorney in Connecticut for 15 years. Jessica is regularly appointed by judges in matters involving conservatorships, estate administration, trusts, and guardian appointments. Also does a lot of estate planning documents and is well-versed in Medicaid. Practices in Westport as a partner of Jones Washburn-Gonzalez, and will, hopefully, again, more when somebody's, as you guys either know or will find out, when someone's diagnosed with Alzheimer's, there are a lot of different things that need to happen and come into play for them to sort of get the right care, and for them and their family to navigate what's happening, and the legal aspect of it actually is an extremely important and helpful one. And finally, we have Rachel Takish. She is the director of the Alzheimer's Navigation Program at Waveny LifeCare Network. She's worked in this field for 10 years with a focus on memory impairment and senior living. And the Navigator program focuses on offering support and guidance to families of a loved one living with dementia, and so thereby incorporates all of us who are here into sort of under. We'll start off with some questions. First, Dr. Radin, can you please explain to everybody how a geriatric assessment differs from just a typical medical office visit? What's different?
For geriatric assessment, we're looking at a whole range of issues, not only Alzheimer's disease or memory problems, neurologic problems, the variety of things that all of us face as we get older. The visit is a long visit. It typically is 90 minutes for the first visit. Right away, that's different than most medical visits. And then in addition to doing a complete history and physical, so we get a pretty good idea about what's gone on in a person's life from a medical point of view, a group of scales that we use, specific issues, mainly depression, memory of functions, nutrition, frailty, balance, because falls are such a big worry for all of us as we get older. The main thing is that it takes time to do all those.
As a follow-up to that, is your experience? My experience is really that sometimes if I know somebody well enough, I might pick it up, or a family member might bring a patient in, having noticed, hey, their memory's slipping a little bit. We see kind of a lack of insight, like the patient doesn't realize it. Do you see that a lot? Or?
Absolutely. So somebody might come in. Well, oftentimes we'll see somebody who is there because a wife or a daughter or a son, rarely a son, but a wife or daughter, brings a person in worried about their memory. And oftentimes the patient themselves is denying that there's any problem. Sometimes you'll have a very pleasant social conversation and talk, and occasionally I'll have the patient telling me something, and the other person that's with them is shaking their head in the back, telling me that what they're saying isn't. And then we do these scales, and you've had a very nice, pleasant conversation with someone. Find out that the level of their dysfunction, memory dysfunction. I saw somebody who was there because of memory problems. One of the things we do, as I said, is balance testing. And this man was well over 6 feet tall, pretty big guy, and his balance was awful. He couldn't stand on one leg. He couldn't do some of the balance. It became a bigger issue. It allowed me to be able to prescribe therapy for him for the balance that might not otherwise been the case. I saw another person today who is a working nurse, came because she was worried about arthritis and maybe some memories. But as we did her depression scale, it became pretty clear to me that she's depressed. And when I brought that back to her, saying, this looks, you might be depressed, she said, yeah, I think I am. I guess I am. So that's going to open up a whole other avenue for treating somebody. It has nothing to do with Alzheimer's disease. It has to do with...
Yeah, and it's memory impairment, Alzheimer's disease, cognitive decline. These are such common issues, and they're dealt with. It's actually getting a geriatric assessment, because it's somebody that it really is its own special. So having somebody who can really look at it and analyze it from all angles and look at, obviously not everybody that comes in with a memory disturbance or a memory problem is an Alzheimer's patient. There are a lot of different reasons why people can have those things going on. It really helps to have somebody that has a lot of experience. So the next question goes to everybody. We're aware that there's a lot of stigma around memory impairments, and people often avoid. I guess from each of your areas of expertise, can you speak to the importance of getting an early diagnosis? Does somebody else want to start?
I can start.
You want to start? Yeah.
I can start. So I think there are a number of reasons to get diagnosed early. For one thing, there are treatments that can help to slow the progression of memory loss in Alzheimer's and pretty much the other memory disorders. Some have been around for quite a while. They're oral medications or patches. They haven't really set the world on fire. They're better than nothing. They're meant to help slow the progression of the disease. They don't reverse the disease. They don't cure the disease. More recently, there have been a whole group of medications, much more complex, given by intravenous infusions that actually treat the disease. And so we're learning now who are the patients who are the people that will benefit by that treatment. Pretty clear that the earlier you do that, the better off, the better the prognosis is going to be. Second area that I think really pertains to a lot of the people on the panel is that it gives you time to get your affairs in order, to make sure that you have documents, the advance directives, the living will, make sure that your financial plans are in order, that your insurance is where it ought to be, and then lastly, my perspective is creating a bucket list, is to look at, what are the things that you always wanted to do, but never got around to doing. Cross off the things that you can't afford and that are pretty impossible, like, becoming an astronaut, and not probably going to happen, but get busy seeing, doing the things that you always wanted to do, talking to the people, healing wounds that have happened in your life, and I think that's something that is a big benefit of getting diagnosed early.
I agree, and I think that also leads into what I wanted to say. People have the opportunity we don't know. So, for example, a lot of people that I have met with in my career have said, I promised so-and-so I promised them I would never put them in a home. A lot of times, if they knew that they had dementia, if they knew that there was something that was going to be a burden on the family, they might say, keep me in the house, make it easier for your quality of life as well as my quality of life. And so it gives them the chance to advocate for themselves without putting the burden on the caregiver, which very, very often.
I would say, from an insurance perspective, it's what I do is more about paying for the services and getting them covered. And generally speaking, as Dr. Radin said, the earlier you identify an issue and deal with it, better the outcome is going to be. And from a medical perspective or a medical cost perspective, the sooner you catch something, the less big it's going to get and the less expensive it's going to be to treat it. Acting early, or as early as you can, you touched on it, there are a number of medications that are coming out. I think the earlier, I'm not a clinician, but the earlier you get on these things and start taking the medications, more you can slow the advancement of Alzheimer's. Medicare recently announced, for example, there is an intravenous medication that now they are covering. So not all new medications are covered under Medicare or any insurance plan, but some are. So the sooner you can get those medications and the sooner they're covered, the better.
I think that's true. I think I was lucky in the sense that John was an attorney, so we had all the documents. Everything was, that was one of his things early on, just get that stuff done. So that part was all set, and we were lucky also to have long-term care insurance blessing. Even with it, I'll tell you, insurance papers are a nightmare all this time. I mean, that was a huge.
Writing, I guess, along with hope, is the idea that the ideal situation is to have your affairs in order. Sorry, I did the same thing she did. So the ideal situation is to have your affairs in order before the early diagnosis. Families have many dynamics, but if you get in front of that and you plan ahead of that, and I realize early diagnosis may mean 50, it may mean 60, it may mean 70. Having your, who you're appointing as your healthcare representative, if you're not able to make those decisions, doing that in advance, that's really important. Or who's that person that you're appointing to be in charge of your finances? If you're not able to do that, that's really important. Even if there is an early diagnosis, it doesn't mean you can't, like Dr. Radin said, put those pieces into play. You can still do that. It's just there's an urgency then where you now have this. It does, over time, continue to get worse. So if there is an early diagnosis, you do want to meet with someone, get those documents in place, but ideally do that before that. And you can always update what you've done. So if something changes in your family or your friends, continuously update those documents. It's really important as memory impairment gets more severe that if you haven't, you want to have those documents in place. Otherwise, you could end up in a situation where you'll be in a probate court atmosphere. And I may talk more about that later, where you're filing for a conservatorship and dealing with sort of a whole different can of worms if those documents had been in place.
And I would just add, I learned, luckily, we had named beneficiaries on all financial accounts, so that was a good thing and expedited, made everything much simpler. But I have heard many people who had not done that, and banks today, despite the law, don't really think that your power of attorney, legally drafted, signed, sealed, and delivered, is good enough for them. And it gets very complicated. So if you can bypass that.
Yeah, I mean, just from both clinical and personal experience, I can sort of attest that, getting everything. So first of all, long-term care insurance generally is worth it, even though it is a pain and it's hard because if you have home care, you have if you have nursing services or 24-hour care, it's a lot of stuff to fill out and submit. It's some of the agencies that charge more and are more everything under one roof will do that for you. Other agencies, you just have to sort of provide them with bills, and it can get complicated, but it's very it can add up, because people can live for a long time with this problem, and so it's good to have that. And the other is just the importance, and it kind of leads into sort of, I guess, Jessica, you started to get into this a little bit, but in terms of elder law and what kind of legal forms, and I think maybe you went through most of it already, just sort of the importance of, a lot of people, they say, oh, well, I've got a living will, I've got my affairs in order, here it is, doc. And you look at it, and it pretty much just says, and I don't know if you guys have this experience, it pretty much just says, if I get to a point in my life where, I need to be kept alive, by artificial means with a respirator and, blood pressure medications and a feeding tube, I don't want to continue. And, the truth of the matter is that, in discussions with your family, we don't really keep people alive sort of against that idea in general anyway, but more, and it's important to have that, but what you really want to do is, I think, and Jessica, you speak to this probably much better than I could, but you want to designate somebody who is, going to be responsible for specific things, like who's going to pay the bills, who can write the checks when your parent can't do that anymore, who is designated the person that, actually, because otherwise the bills just don't get paid, unless you just pay them out of your pocket, but.
Generally speaking, most families that I deal with have one sibling that handles finances and the other one that handles the plan of care. So I would agree that it makes it a lot easier for everyone involved to have a delegated person do everything, because otherwise one person gets overwhelmed. It could be very, very difficult.
What could also happen is, instead of one person being overwhelmed, the siblings that always got along, and that can be extremely stressful on a parent who needs the care, because they may still be able to pick up on that, and the siblings who are trying to figure it out that are now not working in unison because no one was specifically delegated, or I delegated 5 of my children to act jointly. That may have worked if they were all living in a 5-mile radius 30 years ago, but not the case in the world we're in today. Yes, the important thing is to get in front of these things, to delegate healthcare representative. A lot of times spouses delegate it to each other. I always recommend have a backup. You want to have a backup person. Same thing with the financials, but I'm a lot more cautious about powers of attorney. There are laws on the books that protect people who give a power of attorney to someone else, because you can now file in probate court and make the agent, your power of attorney, come in and do an accounting, because they can be abused if they are not people you trust. And I also, if you've got multiple children and you're saying, I'm appointing my firstborn, which a lot of people do, I just say full disclosure, full transparency. Tell your other 2 kids or 3 kids or 1 kid, I appointed, Jessica first, and Hope is the successor. Be honest about it, because the more open and transparent, the less that they'll have to argue about down the line when maybe capacity does start to be an issue.
I would add one thing about living wills. John was very open about end-of-life questions, and we talked about it many times throughout the years. But that's what you want may change over time. How far do you want someone to go to preserve your life may change. And if for nothing else, when the time comes that you may be faced with making the decision to just go home and have hospice care or wherever you are, that you don't want any further care, if you've had that conversation more recently than not, it helps a lot because you're clear as to what the person's wishes are.
And that's why you want to appoint someone that you trust and that you're in communication with continuously, because at the end of the day, you're in the position like your husband was in. You knew what.
Exactly. That helped a lot.
So Jessica, I mean, if let's say a loved one didn't do any advanced planning,
That
then
happens a lot.
yeah, is there a way for a caretaker to sort of get kind of legal authority over decision making?
So a lot of the cases I'm involved with are conservatorships. Those come about through the probate court. Sometimes a person didn't do any planning. And we go back to that situation where siblings may be each trying to help, but banks aren't allowing them to help. They can't sign checks. They can't schedule appointments. They have no access. Procedure would be you file a petition in probate court to be appointed as the conservator of the person, which would be healthcare, conservator of the estate, which is financial. One person can have both roles, one person having each role. Interesting, there can be co-conservators for each of those things. To do that, if your parent or your loved one no longer has capacity, you would go and do what Dr. Radin was talking about. You would have an assessment, probate court form that's filled out, says whether or not this person has the capacity to make decisions on their own, in their best interest. And there'd be a hearing. By law, your loved one would be appointed an attorney, and that attorney would explain this petition to them and represent what they wanted. If they wanted someone else, if they didn't want anyone at all, they thought they could do all this on their own. The good thing about a conservatorship is there is court meeting with a power of attorney. There's no oversight. So if there's no one to see it until it's already done. The one positive thing, about being under the guise of a court is there are regular checks and balances. You have to file accountings. There's that overseer. Probate court costs money. You're filing the petition. That costs money. The attorney who gets appointed to represent your loved one, that costs money. Planning is important, but there are ways to get if planning wasn't done so that you have the ability to make those financial or healthcare decisions in the event that a person, your loved one, no longer has the capacity to do it on their own.
Our next question goes over to Don. Just in your opinion, what insurance, or what insurance maximizes coverage for memory care needs? And are there coverage limitations related to dementia treatments or medications? That's 2 questions, I guess.
The classic insurance answer to that. And it depends. Okay? But it does. It depends on the situation, on each person and each family. But to answer the question, what's the best coverage? It's kind of a tricky question. I think, I was speaking with panelists about this before, it probably doesn't apply to folks in this room, but it would be a combination of Medicaid and Medicare, okay? Because when you're in that situation, you're not paying any premiums, you're not paying anything out of pocket. Basically, the government's covering all of your needs. But being dual eligible, which is the technical term, effectively means you really don't have any money, okay? So not everybody can get to that. Some people, unfortunately, are more or less incentivized to do that, okay? That said, since it only applies to, a few people. Other than that, I would say what you really want, and assuming that we're talking about, but you can't really assume that we're talking about Medicare here, because memory loss, dementia can start earlier. It would be any kind of a good, solid medical plan, but if it were Medicare, I would say everyone's got to have Medicare A and B, and then a Medicare supplement plan plus a suitable prescription drug plan, as opposed to a Medicare Advantage. And not trying to say there's anything wrong with a Medicare Advantage plan. I just think that a better coverage would come through Medicare supplement plus prescription drug. If there, as far as limitations, it is important to know that Medicare and medical policies in general only cover medically related services. Okay, when we get into memory loss, care of elderly people, it's not just medical, it's getting around. It's the activities of daily living, and that comes right into a long-term care insurance policy. So, if you want help just getting out of bed and getting dressed and getting back into bed and eating, and there's a standard list activities of daily living, you would want a long-term care policy, and that's a big thing to look into. It's a financial planning discussion. It's can you insure all of it or some of it? How much you're going to pay out of pocket? But again, a combination of the two, of a good medical plan to cover the medical needs, and then long-term care if in fact you've thought about it ahead of time and you feel like buying it ahead of time and spending the money ahead of time. My father, personal experience, both my parents are in Florida and they don't have dementia, but they're old, they're in their 90s. And my dad needs help getting around. They're living in their house, they're still, still sharp. Although my mom is having a tough time keeping track of the medical appointments. So now we're working on that now. Between myself and my sister, we're figuring who's going to do what, and we have a plan. It's coming together, but not easy to do. As far as limitations are concerned, I'll answer the question. Medically, typically with Medicare, you don't really have limitations. You have what's medically necessary or not, and then you also have, typically physicians, do they all participate in Medicare? Because not all do. Most, the vast majority do. And then there's just the limitation on the long-term care policy. You can buy a policy that pays your caregiver $300 a day or pays $300 a day or whatever the number may be, up to a lot. At-home caregivers can be expensive. If folks my dad gets 8 hours a day, and that's about $300 a day. Those are the potential solutions with insurance, but also potential gaps.
If I may, since you're an insurance person and you can't say bad things about certain insurances, I will. I personally...
Yes, I can.
That's fair. I personally, in my experience in hospitals, short-term rehabs, as well as assisted livings, have found that managed Medicares are more of a problem than they are a solution. I find that they do not offer the appropriate coverage for people. I know there's a lot of advertisements for them these days, which is why I'm choosing to bring this up. But traditional Medicare, in my experience, is a more beneficial plan. Managed Medicares are exactly that. It is your Medicare plan managed through a third party. And so there's a lot of authorizations and coverage issues and hoops to jump through in terms of continuing the coverage and the support that you need from your insurance provider. So,
Hope, we're really fortunate to have you here speaking with us, and thanks for coming. If you could just sort of share with us what the sort of diagnostic process was with your husband, John, and what first made you realize that something was wrong.
When we actually got to the diagnostic process, it was very straightforward. We made an appointment with a neurologist who was wonderful and sensitive and spent a lot of time with us in his office and was pretty sure he knew what was going on, and then sent John for a PET scan. He had something else that could make an MRI not possible. There was a clear pattern of Alzheimer's shown at that time. So he was told, he knew when we went to that doctor that he had been having gaps in his memory, and he was not worried about it, but he was perplexed by it, which was really interesting for me to see. When he was told that he did have Alzheimer's, it was devastating. And so that was really tough. The thing that did happen, luckily, I guess, and not terribly long after that, a couple months later, he had detached retinas in both eyes at the same time. So that meant he had to have eye surgery with a week of face downtime and all that stuff. It was complicated. It gave me, it changed the picture in his head. So he really pretty much forgot about the diagnosis. It didn't come up again. And I was able to use it as a reason to say, you can't drive, you can't do this, you can't do that, which was all true, but there was more to it than that. There was a lengthy period of time before the diagnosis. We didn't jump to do it right away because honestly, I had been through the same thing with my mother. Actually, I think there was some overlap. So I recognized what was happening, at least at that time. There really wasn't a whole lot that could be done that was going to be particularly effective. So I didn't think it was really worth putting him through that unless we got to a point where it became important, which did happen. The early signs, the big red flag was this man who had been meticulous about all of his record keeping and of all kinds. He was an attorney, he was nitpicky about things. Came time to do our taxes one year and everything was chaos. Uh-oh, this is not good. So we hired our daughter to take over paying the bills and keeping track of everything, which worked out well because she was, I've forgotten exactly, either between jobs or doing something, she needed a little more money. So we were able to pay her something nominal. And then if John started to say, well, I'll write that check, I'll do this or that, she'd say, Dad, no, don't take my job. You can't fire me, and that worked out well in terms of our family. So, because he did want to, in a beautiful, generous spirit, he really wanted to give money to everyone who called. And we all know how they call. I mean, I eventually disconnected that phone. So nobody call my home number. I don't answer it. It's not even plugged in now. But we had to be really careful. He booked us on a cruise. And luckily he didn't have a credit card, so they had to call back, and I was able to tell them we really weren't going to be traveling with them. You do have to be aware of all those things. And anyway, so the process was very straightforward, but the preamble, once we had a diagnosis, it was helpful to me because it validated things for me. I did do one thing, which I will mention now. When he started being forgetful about things or messing up paying or doing different things, I started to make a log. I just kept it on a note thing on my phone or on my laptop. And I just would write a date and what happened. Very simple, but it was helpful to me because it helped validate in my eyes that these things were happening with some regularity. It began to show patterns. The end of the day was tending to be worse. And when we did get to the point of having a diagnosis, it was very helpful to the doctor because I had a whole log of things that have been going on.
Any barriers or sort of hurdles that you had to sort of, that you didn't expect were difficult? Or?
I don't think anybody really knows what to expect. There were lots of, barriers. I sort of translate that to mean really tough things. What was the really hard stuff? I think recognizing early on that this was happening was hard because I had just gone through it with my mom. And but we were organized ahead of time in terms of insurance and legal documents, so that did help. The hard things were loneliness, because particularly early on, trying to be protective of your spouse. Here's this brilliant man who's done so much particularly for New Canaan, was 10 years as a state rep, which many people know, which he loved. But so because of that, a lot of people knew him, and I wanted to protect him from embarrassing himself or getting into situations that were potentially dangerous. So that was hard, but over time it became obvious to anyone who knew him well, and I was told early on with my mother, actually. This isn't going to be a secret for very long. It's you're going to need your support team. Can't do it alone. So keep your own life going. It's going to be critical. You're going to need your buddies. Tell people. They may have ideas or helpful hints for you. And if nothing else, they'll listen to you when you're going through a tough time. So I think that particularly that early time is, it's a stigma. No one wants to say. I think John's really kind of losing it. I mean, you don't want to really almost believe it yourself, and you certainly don't want to say it in general. So there is a tough time then. And I think also, even though we did have all the legal documents, we did have the long-term care insurance, it is horrifically expensive to get the help that you need. And you need the help. I mean, this is a disease that can go on for a long time. And I mean, physically taking care of someone, often you get to a point where you need two people to help move someone. And not knowing if it was going to be 2 years or 20 years is concern for most people. So finances were scary. The ongoing frustrations over the changes that you're seeing, and the sadness of the loss of the person who, you've shared your life with, you love, and over time they're not the person that they were, and they're increasingly confused. And those are the hard parts.
And this kind of leads into our next question a little bit too. And I personally, my experience is always what I find is that very often spouses or family members trying to also be the person's caregiver. Like what's our wedding vow? It's till death do us part, through sickness and in health. And the problem is that's really not what your relationship has been for the last 50 years, and it's kind of shouldn't be in some ways. And so and Dr. Radin, you may be able to speak to this, or maybe you approach it differently, but I try to tell people, as soon as you start to feel like you need help, you get it. You get help. Don't try to, bathe your spouse, and, you don't try to be their nurse or their home health aide or that, be their spouse.
Not all of the memory problems, not all of the dementias are Alzheimer's. So when you do get an evaluation and such, sometimes it is very difficult. The memory loss down to Alzheimer's disease or Lewy body disease or strokes or whatever. Behaviorally, it doesn't make all that much difference. There are subtle differences from one to the other. Yeah, sometimes in that beginning, it's very difficult to label things, and that can be very, very frustrating. I think Hope's journey was definitely typical. I right away in the beginning, also recommend that people, first of all, don't hide the diagnosis. That's so important. And I can tell you, I don't know, Peter, if you've had this experience where I've had a husband that has a wife that has fairly advanced Alzheimer's but has not told anyone, might have tipped people over. So then the guy gets sick and he gets hauled off on an ambulance to the hospital. And here's this poor woman who cannot survive by herself to the hospital for a, quote, social admission so he could get somebody, get things safe. I'm a medical director of a nursing home, have been for way longer than I would like to think. And occasionally we have to admit to the nursing home somebody who is there for, let's say, short-term rehabilitation after an orthopedic surgery or whatever, because the other person has enough disability that they can't be by themselves. You need that care team. You need family. If there's not family, friends. You need to have, for an organization, somebody that's going to be able to help you in a pinch, and also then, as things get worse and worse and time goes along, to be there for caregiver support. So important. What you did as far as recharging your own batteries, but sometimes you need to be able to get away.
Yeah, absolutely, you have to.
For respite, try to tell folks, at least twice a week, you need to have time for yourself, even if you're just going to go shopping or you're going to, go to lunch with somebody or whatever.
You need that, and you also need the social contact. I mean, it's important for the Alzheimer's or the dementia patient as well as you. And I think when John was diagnosed officially, it was September 2020, or that fall, maybe it was October by then. But because of COVID, isolation, I really believe, exacerbated and sped up his decline. Things that he had been doing New Canaan has wonderful organizations, the men's club, this group, that group, all get together and chat and talk about things and whatever. Those things are really important, and I saw big changes when he was not able to go to those things, and Zoom wasn't going to be a good deal for him. I mean, that was like not happening. So, I mean, I set up a few Zoom Lapham history lectures, which he liked. It was only semi-successful. I think the social aspect of the whole thing, getting out yourself, it was critical for me. It's hard because you're losing the person who you've shared everything with, and that's enormous. And it gets, you lose them bit by bit by bit, and one day you're looking at this person and they're maybe not so sure who you are, and those things are hard, so you need the support. And I really am internally thankful for the aides that we had. We had beautiful caregivers that started just a couple of afternoons a week, and then it built slowly, and then pretty soon we ended up with 24/7 care. And for a while, we even had to have 2 people during the daytime, which was a lot. And at that point, I began to think, I don't know if I'm running a nursing home here, or maybe this isn't going to be possible. What happened was the live-in caregiver actually went off on a vacation, and she was fabulous, and she wasn't small, and she was strong, but she couldn't physically handle him by herself safely. We'd gotten to that point, and a man came to take over, and he was an angel. He was great with John, and so we just had him stay, and the former person got a different position. But so my point is really that finding the right aid and maybe even reassessing that at sometimes is key, because his needs changed, and it all gets down to dynamics. You're going to have these people in your house, and if you're doing it at home, so you have to like them. They're going to be your family. They're helping you through the hardest time. They have to be good with the patient. They have to be good with you. They have to kind of fit into your life in many ways. They are a godsend. I don't know how they do the things that they do.
The people that are in that field are incredibly dedicated and compassionate, and have, like, it seems like almost unlimited patience.
And one more thing I'll say about them is they helped me when I would get really frustrated with things that were going on, or particularly towards the end when this wonderfully sweet, consummate gentleman of a man I had been married to for so long started to get really nasty and swatting at the aides and speaking to them in ways that were just awful. And I got furious, and I reamed him out and said, you will not talk to anybody like that way in our house, and blah, 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 blah. And they pulled me away and said, "Hope, this is the disease. It's not John." And we understand, and so they were really helpful to me at some moments like that, and I thank them for that also.
Dr. Radin, would you kind of say this is a sort of, her journey, it sounds like, to me, it sounds fairly typical. Any other, just in your experience, the old medical school example is when someone can no longer balance their checkbook, that kind of stuff, or they can't do their taxes anymore. What kind of, I think it's kind of come up, sort of other things, but the earlier you can pick up on the smaller things, the easier it is to avoid, having a family member who suddenly in their car is 2 hours away and needs to go be picked up in the middle of the night, or, financial catastrophe because, you suddenly realize that all these cold calls and these telemarketers and these letters that you're getting in the mail that are just junk mail, when someone doesn't know any better and they start taking every single thing seriously, are there other things you feel like people can look for?
Probably early on, one of the annoying things is repeating questions. Somebody who's asking same question over and over again. What are we having for dinner? We're having such and such. And 10 minutes later, oh, what are we having for dinner? Or you're getting ready to go out, you're putting your coat on, and then you get in the car, where are we going? So those are, signs. It's not just, those are a little bit more than something that we call, senior moments. When you walk into a room and you're not quite sure why you're there, and then all of a sudden it comes back to you. This is this is more repetitive. It goes on. And the way you can tell that it's not right is it's so annoying, you get angry. So that's a good diagnostic test.
It's because there's no insight. The
Yeah.
person doesn't say, "Oh yeah, right, you told me." Like the person doesn't have any recollection that they just told you that story
Right.
5 minutes ago, or that
Right.
you just answered that question.
So the Navigator program is a free program for New Canaan residents that are dealing with Alzheimer's and dementia. And our goal is to provide to put it simply, a one-stop shop for the residents of New Canaan to be able to get the support that they need. So myself and my team, which is Nicola and Kathleen over there, who will be collecting your questions when you guys are ready. The three of us run a 24/7 business, and we are available at all times for our clients. And the goal is really just to provide the support. As Hope had mentioned, obviously, the support for the person with Alzheimer's and dementia is extremely important, but also the caregiver does often get left behind. And if you can't take care of yourself, you cannot take care of somebody else. So we give them priority access, into Waveny's network of services, as well as just giving them education and knowledge into advice for what their next steps should be. So there is a handout on the table over there with information about it if anybody would like to learn more, and also my business card is there as well. Thank you. I'm sorry, I meant to say that. I got off track. Yes, we do have support groups every third Tuesday of the month at Waveny LifeCare Network. And so one of the things that you had mentioned earlier was how helpful support groups are. And so we have that, and we also have social gatherings as well, where we have the people that are on our program socialize without the person with Alzheimer's and dementia. So that way they're able to find that commonality and relax a little bit without having to worry about taking care of the person that they are very, very often taking care of. So it's a very exciting program. We did just start it this past year, so it's something that I think our community is really, really going to benefit from, and I'm very, very proud to be involved in it.
Yeah, I mean, the notion of having everything kind of integrated into one place and, everybody kind of working together under one roof is totally outstanding for this kind of a problem, because so often you refer somebody to Dr. Radin, and he'll assess them, make the diagnosis, but then there's the issue of, okay, well, where do we go? Which place do we go to? What kind of services do we get? How do we get home care? What agency do we call? How do we pay for it? What kind of insurance do we need? And it's a little whack-a-mole. There's always something that's kind of popping up, and oh, there's this too. And so to be able to kind of have it integrated is really helpful, like a place where you can call up and say, hey, this is where we are.
Yeah,
What do we
thank you.
do? And kind of getting plugged in can be really helpful.
Yeah, it's essentially a care management program for free. So we are very, very happy to be able to offer our expertise. Dr. Radin, I know you were talking about what are things that we can see that are standard, and what are things that we can see that are kind of a signal that something might be wrong. And so to go off of what you were saying earlier, one thing that I find is not that talked about very often is word finding issues. And one of the things that I've noticed is that some people, when they are a little bit more self-aware that something is going on, they'll start becoming much more quiet. And my mom is sitting here in the front, and I'm going to use her as an example. I'm really sorry. Not her, my grandfather. Sorry, Mom. My grandfather was recently diagnosed with Alzheimer's and dementia, and unfortunately, my mom reached out to me about it, and I said, I still to this day apologize to you for not telling you earlier, because I thought it was obvious, because it was something that I deal with every day. But her father, my grandfather, is a very social person, very funny, very talkative. And when I had gone down to Florida, he was getting much more quiet. And I realized something was wrong in those moments, because he was becoming more reserved as a way to try to protect himself, because he knew he didn't know the right words. And that is something that I have found is a really easy way to tell something is going on, that is a little bit more intuitive to notice. So I just wanted to bring that to everyone's attention.
Yeah, I mean, smarter people are better at hiding it, for sure.
That's what
in
I
their
was
own way.
gonna
I mean,
say.
it
Yes,
can
my
be
mom's-
harder. It can be easy to be like, yeah, he's gotten kind of quiet in his old age, or
Right.
yeah, I mean, you just don't even realize it, because the person will start, sometimes people will start. What they do remember more is they don't remember their more recent past, but they remember everything that happened to them when they were kids. So they'll start talking about that like crazy. You'll hear all about what it was like for, grandpa or dad to have gone to middle school in Brooklyn in, 1948, but he can't tell you, what he had for lunch today, So, and dad, and somebody who's smart there is a lack of insight, but they do tend to just grab onto what they know. You go with what you know.
Something else that I find, I think we all are aware of the increased frustration and agitation. That reasoning with someone with Alzheimer's and dementia is extremely difficult because that logic just isn't really there. But I've also found that a change in hygiene is a good indicator as well. If you have someone that's always kept a very tidy home or a very neat checkbook and taxes, and that's changing, that's showing you that something is wrong. And if they're not showering as often, if they're wearing very similar clothing, like a lot of times you'll see the same shirt over and over, and that's because that shirt was left on the chair yesterday, and then it was the first thing they saw, and they put it back on. So, and there's nothing wrong with people wearing similar clothing all the time, obviously. But yes.
But it's not always a sign of dementia, right?
Not always.
Some
no,
of us
I
wear
mean,
the same thing more
it's
than
not
once.
always. It's a great cardigan you're wearing home, but wear it every day.
It's white. It
Yeah.
goes with everything.
Okay, so we've got some questions from all of you. Thank you for passing some in. So the first one's for Hope. The question is, once John's dementia had set in, what were some of the things you could happily do together?
We could happily do together.
Yeah.
Well, for a while, we could still go out for dinner with our friends. Our neighbor, particularly, she's here, and we would go out for dinner or go out for lunch, go for walks, as long as we could do that. That was just a nice thing to be able to do. We could get in the car and go for a drive, go to the movies, things like that. But as it progressed, one of the things that happens, I think it's not unique to us at all, but even people who are your friends, people who are you can count on for anything, they tend to withdraw. They don't know what to expect, and people can be a little bit afraid, or that they might find themselves in a situation where the person says something off the wall and they don't know how to respond, or it's just not a pleasant idea for them to say, okay, let's do such and such. So I think the more you can get out, the better. Even when patient gets to a point where it's either physically difficult or whatever, you still need to do that.
Dr. Radin, this one's for you. What age is considered geriatric for geriatric assessment, and when should one have this assessment? Only when there is issue, or is it general good health?
The age of geriatrics depends on the age of the practitioner. And as time goes along, I can tell you that most of you would not qualify for that. Generally, we talk about 65 as the age, but probably most of the patients that we see are at least in their 70s, if not 80s. Occasional, and some of the patients are in their 90s. But I would think that mid to late 70s is fairly common. People are still working. I'm an example, but people still working, well beyond the retirement age of 65. Which, as far as a lot of it depends on who your primary care physician is and what your general health is like. If you have a really good primary care internist or family doc that provides comprehensive service, I think you don't need to run to geriatric assessment. I think that if you're making changes in your life, that you're retiring, thinking about or getting a sense that maybe something's wrong, the assessment doesn't hurt. It's actually covered by Medicare. So it doesn't hurt in the wallet, and we don't stick needles in anybody.
Second question for you also, I guess. Please address side effects for medication for Alzheimer's. And I guess that's sort of like Aricept and Namenda?
So the most common medications, donepezil, which the trade name is Aricept, or memantine, which is, most of them don't have much in the way of side effects. Aricept in particular doesn't tend to have much in the way of side effects. Some of it's dose dependent, so at the low doses, hardly anything. At the high doses, more. The thing we worry about the most is probably nausea and loss of appetite. Weight loss, which sometimes is a part of the disease itself. The medications can do that. So typically, watch somebody over the first couple of months of taking any of the medications, particularly when they get to whatever maximal dose that you might be using. Some patients will complain they just don't feel well. They don't feel right. They don't feel themselves. It's a very vague kind of a sense, but that's a second. Rarely is there any other, central nervous system type sedation, hallucination, that sort of stuff. That's quite rare. Most of them are very, very well, very well tolerated. The new medications that are now being done by infusion, that's another whole story altogether. Probably not necessary at this forum,
But Dr. Radin, one thing that happened to John, and I didn't anticipate it, I didn't know, but as his disease progressed, as he got older, the neurological changes in his brain meant that he was then metabolizing medicines he'd taken for a long time differently, and some of them then start to cause problems. So even though there may not be, may be something you tolerated well for a long time, it can change.
Oh, yeah. You have to look at the whole, that's not just for the Alzheimer's medications, the memory medications, but for the whole, medication list. Almost everybody that's in this, having memory problems and such, they have, the other stuff that goes along with it. The hypertension, the diabetes, the, arthritis, other common problems, and so they're usually taking a whole bunch of medications, and you have to look at each of those as a matter of aging, as a matter of interactions between one and the other. The other thing I would say is that behavioral problems with patients that have dementia are very, very common. You mentioned getting nasty and getting aggressive. It's very, very common. It's treatable. It takes somebody with experience oftentimes to treat those properly. Those medications all have significant side effects. And so they have to be dosed at very low levels with careful titration against symptoms. They can cause a Parkinsonian type side effects. They can cause sedation. And sometimes they can cause a paradoxical effect of increased agitation, and so you have to look at those. But those are medications that are usually later in the disease when people have more more behavioral issues. Not everybody has behavioral issues, but it's a significant problem, and it causes gigantic disruption in the home. It becomes very, very difficult. In some instances, to keep people at home because the caregivers run away. The aides and such, they get hit, and get insulted enough. They say, I can work elsewhere, and so it becomes a problem.
Okay, great. Don, question for you. What if you don't have long-term hair insurance?
You pay for it out of pocket, at least for the basic, assistance with living, like we are. You do your best. You got the medical covered, and Medicare. I say to people, most people, or a lot of people, don't look forward to turning 65 until it comes to health insurance. Okay. Because Medicare is, I call it, the golden land of health insurance. And rightfully so, I think. My folks can't be dealing with copays and networks and all the stuff that we all have to deal with, at least us under 65ers. I'm close, only one more year. Yeah, if you don't have long-term care insurance, you don't have it, and you can't get it later in life either. They will issue policies, depends on the insurance company, up to quite an advanced age. At least, I think you can get something up to 80 if you are, in fact, cognitively suitable for it. And a lot of the long-term care policies, it's not a medical policy, so having a sort of a medical issue is completely different than having a cognitive issue. So the tests aren't really medical. They're not taking blood tests necessarily when you go through underwriting for long-term care. But they are asking questions. They're doing a cognitive assessment and seeing and they'll ask also family history. So that can come into play. So keep that in mind. If somebody is considering long-term care insurance, you go through underwriting. And the questions, just like a life insurance policy, some health insurance policies, is anybody in your family have dementia? And, you have to answer those questions truthfully. So if you don't have it, you're paying. You just manage it. Hopefully you save your money. Now, if you don't have the money, and I might sort of pass it over to Jessica, but if you find yourself or a friend or a family member who has dementia and needs and is going to need care and an increasing level of care, and it's going to start costing some money. It comes back to the Medicaid situation where you may have to go that route. And I will sort of turn it over to Jessica, but if that's the case, there's a process by which family must go through to effectively spend down their assets to qualify for Medicaid, and eventually you're going to kind of go through your money anyway, paying for long-term care.
Sure. So Don started his first answer tonight with the best insurance you can have is Medicare and Medicaid. I don't know if people understand the difference, but you get it in a year. You'll be 65, right? Medicaid is when the state picks up the tab, so to speak, and there's a process that you have to apply for, and there is a 5-year look-back window for that process. People who are worried about having a lot more, a nursing home can cost $16,000 a month. Having someone at your house can cost $12,000. Plus insurance, plus homeowners insurance, taxes, transportation, medication, talking a lot of money. So you have to have a lot of money to actually be able to pay all of this out of pocket. So there is a side of what's called Medicaid planning, where before someone actually needs to think about transitioning or needing full-time care, you can plan ahead. And that may mean protecting the assets you have, plan to keep them out of the 5-year look-back window. State, when you apply for Medicaid, you want 5 years of bank statements. Any deposit or withdrawal over, it could be $1,000 or $5,000, they're going to want to see. It's a process that, it's a big process. But instead of coming to an attorney and saying, my father is 88 years old, he's got a house with no mortgage, and he's now in the nursing home, and I don't know what to do, he's only got $30,000 in assets. If someone would have come, 10 years back, 5 years back out of that look back, there's a way to protect what your father had. Whereas if you come at a certain point, you're right, there's a spend down. You have to spend down those assets to $1,600 or less. Doesn't count your primary residence or one car. It does count the cash value of a life insurance policy, that counts. You can have a burial contract up to $10,000. That's excluded. But there are all these rules and regulations, and there's a lot that goes into being proactive in the thinking instead of reacting. And it's complicated, so I hope I haven't complicated it. I hope I've given you just a couple good nuggets.
Jess, can you talk about gifting a little bit? I know people...
Yes. So I have a lot of people who are like, we sold my dad's house. He's going to transition into assisted living. He wants to give each of us kids $50,000. You can't. If you are worried that you may need Medicaid. In that 5-year look-back window, they're looking at those gifts, and you will be penalized. What being penalized means is Medicaid, the state is not picking up the tab. There's nowhere for them to go, or the family is having to. So you have to be very conscious about what gifting is and what the ramifications are, keeping in mind 5 years. Like if my mom is 70, she wants to gift us all now, the exclusion, let's say $16,000. Fine, because my mom's in good health, 30 miles a day, she does all this stuff, fine, great. She could probably make it the 5 years. But if she's doing that at 80 or at 85, if she ever needs Medicaid, there are gonna be penalties assigned to her, and those benefits and services, the great insurance of the combined, she will not have, at least not for a delayed period of time where she's probably living with me. And you can, there's 2 different types. There's the home care program. So you can be on Medicaid and get home care program. Live in your home, they will do an assessment, and they will say, these are the number of hours that we're willing to give, that the state is willing to pay based on your assessment. That goes back to those ADLs, that goes back to behaviors, a lot of things. And they may say, well, you get 12 hours a day, and they'll pay for that. If, however, the amount of hours aren't enough that the state is willing to pay, or the person just cannot, with their income, still maintain the home, and they have to go into a skilled nursing facility, yes, they will require they will grant the benefit. You provide them with a listing agreement for the property. And then they will grant, if everything else is set, you provide that listing agreement. There's a redetermination that happens 6 months later. And in that redetermination, they're looking to see what happened to the proceeds. So if those proceeds disappear, it's a whole other, big problem, right? And at that point, become a criminal thing and a lot of other. But if they're just sitting in the person's bank account, well, guess what? You're no longer eligible for Medicaid. So those funds have to be used at 15, 10, 16, 12,000, whatever it is a month. And then when you get spent down, you then reapply, and you have to be able to show how those funds were spent. So it's not in a revocable trust, because revocable means the grantor has power. And if I have the power of my house, I have the power to sell it. So a vehicle used is an irrevocable trust, but a lot of people, no way, an irrevocable trust, I have no power? How do I know you're not gonna kick me out and I'm gonna, An irrevocable trust takes it after 5 years. There are different planning mechanisms you can use. A revocable trust just doesn't work because the grantor still has the power. There are ways around it.
We always recommend the person seeks the help of an elder law attorney. This is very, very complicated, and there's so many individual situations. I've had families that where a house was deeded over. The person went into nursing home, and the recipient of the deed refused to let them back in the house. So they were stuck in the nursing home, even though they didn't need to be there. They had no other place to go. If you have someone living in your home, a relative who is not a spouse, not married,
Caregiver exception.
The spouse,
Yeah.
back years and years ago, state would foreclose on a house, and the spouse was out in the cold. That went away many years ago. So the community dwelling spouse can stay in the home. The state will come after the money when it's time. If it's not a spouse, then they can come and the person is left without a place to live. There are so many of these situations that it's so important to sit down with an attorney who can really ask all the questions. And these are hard questions, and force, because it's very easy to look at this and say, tomorrow, we'll discuss it tomorrow, we'll figure it out next time. It's absolutely worth seeing the attorney.
I do believe Jessica's business card is on that table back there as well.
Thanks.
Okay. Thanks. That's a
right, yeah.
huge information. No,
It's good.
it's great. Yeah, it's fantastic. This was also on our questions that we didn't get to, so it's come up. We discuss, I guess this is for you and I, Dr. Radin. Can you discuss how you handle driving patients with Alzheimer's, and especially if they refuse an assessment?
So one of the things we do in the assessment process is check safety. So home safety, And then driving, obviously, is a big, big, big deal. Sometimes it's easy. People who are driving, they're not getting lost, they're not having accidents, and they have restricted their driving to a relatively small area. Don't do anything at that time. On the other hand, if there's serious concerns, some people will voluntarily give up driving. Around here, that used to be very, very, very difficult. It isolates a person. It's a little bit easier now with Lyft and Uber and some community, services to get people around without them. If a person does not want to give up and they or their family or I'm worried about their driving, I try to get them to agree to a driver's evaluation. So there are 2 or 3 programs around that do driver evaluations. Easter Seals has been doing one for many, many years, and they include a road test. Costs between, I think, $500 and $600 for that evaluation. I can't imagine the bravery of the person who actually gets in that car for the road test, but be that as it may.
Driver when they have a brake on the side.
Because they're going in your car. That's one. Norwalk Hospital has a driver evaluation program that mainly uses the occupational therapists do it and may use a simulator. One of the neurology groups up in Danbury has been doing a driver evaluation program. The deal I try to make with the person is you do the driver evaluation. If they say you shouldn't drive, give up the driving. At the same time, you have to figure out how these people are going to get around. If you can't drive, you're stuck, stuck in the house. So you need to have a plan. One of the things that I've done is have people do, with Uber or Lyft or one of the regular visit. Every Tuesday, every Friday, the ride comes, and you can go out and get things done and go around. And then you might want to check. Rachel, I'm sure you know this is something that must come up in the Navigator program all the time. Community services to drive. In Wilton, we have a group called Stay at Home Wilton that will provide transportation.
Mm-hmm. Here in New Canaan, we have staying put and get about. Taking away the car keys is extremely difficult for many reasons. One of the things that I personally find is the loss of independence is a really, really hard thing for someone to give up. And I think we can all agree with that, whether you faced it or not directly. So I do find that using a authority figure as the reason why you have to give up your keys usually is a little bit easier than being the bad guy themselves. Say, oh, Dr. Radin said.
Tell him he can't drive anymore.
Yeah.
No problem. Happy to play the bad guy.
And that typically works.
All the time.
Also, sometimes you just have to hide the keys. Out of sight, out of mind, especially with memory impairment. And sometimes people will fixate, and you will have some uncomfortable conversations and some tough times. But there is information on that table over there as well about the testing sites that Dr. Radin has mentioned on our local resources handout that we put together. So. We do want everyone to be as prepared as possible and try and keep everybody safe because it is scary. I don't even need to have, any memory impairment. I'm not the best driver, as my mom knows. So.
Yeah, so both of those are great points. I mean, what you're really taking away is the person's independence. So what I always try to do is focus on, well, you're not losing your independence necessarily. You can still call an Uber, or you can get a ride, or think of it like somebody's now driving you around. I try to slant it that way.
Make it fancy.
Yeah, exactly. Like look at it now. Now you get a driver. You just don't have to actually get behind the wheel and drive.
I'll just throw the monkey wrench into the conversation from my experience. And that is that I tried saying that to John, and look, you've got Uber, no problem. You just put this little app on you can just push the button and they will come and get you, take you wherever you want. First of all, technology is scary, and it's like calendars and time and clocks those are skills that tend to diminish, and using an app like an Uber or Lyft app is not going to really work too well.
Right. It just assume like someone would do it for them.
Right. But that's then the independence is not happening. And so anyway, I got a lot of you got to be kidding kind of stuff about that.
I'll throw another wrench in the works. Well, if you have a caregiver from an agency, home health aide, I don't know about all agencies, but I know ours, they will drive you in your car. They'll drive you, okay, anywhere you want to go. That's one of their jobs. The catch is getting my dad to say, oh, sure, I'm going to let you drive me? I don't think so. So it's, same thing.
I've had a few clients who this has been a really big deal, and a really big deal in the sense that the police stopped getting on the off-ramp for 95 in South. What I have found in these cases is sort of like out of sight, out of mind. It's not just the car, the keys, it's the car. And I have involved the police, fire, ambulance, and notified them the car is being removed. Because even though I may say to a client, we have to remove the car today, and maybe it's for repairs. Maybe they may not remember when they wake up in the morning, even though the aide, maybe they're telling them, no, the car is safe, they may still call the police and report it stolen. And I've had that happen too. And I've had the police call and say, thank you so much, you're right, it happened. They called and they reported. Or I've had it parked in the garage, but they forget that it's in the garage, out of sight, out of mind. So it obviously is going to depend on where on the memory impairment spectrum the person falls. But there are times where I'm not waiting for a doctor's appointment when I have a client who's trying to get on the wrong way up the off-ramp on 95. So at that point, though, you do take the proper, by letting the police know, letting the proper channels know, I'm removing the car. So if they call and say it's stolen, it's not, it's secured. They're not able to drive it. We're working on getting an appointment to verify that.
Thanks so much. Thanks for having me. Thanks for having all of us. Thanks to our panelists for joining us. Our town we are lucky having lived and worked in this town for 5 years. Waveny has always been a tremendous resource and continues to be. And as a physician, I'll say that, one of my patients needs somewhere to go. And it sounds like a shameless plug, but it's just true.
Thank you so much to our panelists and to our moderator and to all of you for coming tonight. Hope you make it home safe. I'm sure you will. Thank you.
Thank you.